Bienvenidos a todos. Good afternoon. Welcome to En Casa con la Plaza. En Casa con la Plaza is direct from our home to yours from La Plaza de Cultura y Artes. It's our way of bringing these conversations, presentations, demonstrations, and performances 3, sometimes more times per week. It's our way of fulfilling our mission to tell the little known stories of Mexicans, Mexican Americans, and all Latinos in the founding, growth, and evolution of the Los Angeles region. If you're joining us on Facebook, please, we have our chat feature. Let us know where you're viewing from. Also, we have a Q&A, as you know. If you have questions, go ahead and put them in there. We may save them for later, but please ask. Those of you on Facebook, we have our comment section there. Let us know where you're viewing from. And also, your comments and questions are welcome. We're sponsored by SoCal Gas and California Humanities, making these sessions possible. Today, we have a very special and very important program for you. The impact of COVID-19 on Latinos, the way forward. Moderating today's panel, we have a great panelist. We have Giselle Hernandez. She's a research assistant at UCLA's Center for the Study of Latino Health and Culture, and one of the writers for the center's podcast, Gente and Health. She has co-authored research reports examining the relationships of Latinos, COVID-19, and telehealth, as well as historical publications, Somos UCLA, and always have been, 3 Latina alumni of the LA State Normal School. Born and raised in LA and part of the El Salvadoran diaspora, she's interested in Latino health and the intersections of health and Salvadoran history in LA and beyond, and making her debut online. Please welcome Giselle Hernandez. Giselle?
Hi, thank you so much. So yes, my name is Giselle Hernandez. I am a research assistant at CESLAC. And thank you all for being here as we delve into these important topics of the impact of COVID-19 on our communities and delving into the structural barriers that our most vulnerable communities are grappling with during this pandemic, and what that's looked like with the Latino physician shortage that's been an ongoing issue in California for decades. So we're going to have 3 amazing experts give their insights, and as you hear each of their presentations, please do write down your question in the chat or the Q&A, and then we're going to get to it at the end. So first, we're going to hear from Dr. Hayes-Bautista, Distinguished Professor of Medicine and Director of CESLAC. His research into Latino health and culture, including the Latino epidemiological paradox and Latinos' historical presence in the US, has led him to study the links between culture, behavior, and health, as detailed in his books, El Cinco de Mayo, An American Tradition, and La Nueva California, Latinos from Pioneers to Post-Millennials. All right, Professor, take it away.
Thank you. First thing I'm going to do is share screen, because I want to share with our audience some findings that we have come through. So I want to chat for the next few minutes about Latino health and social narratives. Sobre todo narratives about Latinos. So ever since April, COVID has been the major source of death in Los Angeles County in the state of California, and then as well as across the country. And early in the pandemic, the issue arose, why do Latinos, African Americans, why do populations of color have higher death rates than non-Hispanic white? And in the middle of July, as we see here, the Asian death rate compared to white is about 50% higher for Alaska, American Indian, Alaska Native, Native Hawaiian, Pacific Islander, and Black, about 4 times as high, and Latinos about 5 times as high as non-Hispanic white. So it's very clear something is going on, but what? The question is why? And this is where narratives come into play, trying to answer this question, why the high Latino COVID-19? So this is the most important thing. This will be on the final. Just kidding, no finals. But remember this, facts tell different stories depending on who is picking them and placing them in a narrative line. Well, what do you mean? Isn't research objective? Well, let's take a look. There's a narrative that we have all suffered with. It's called the narrative of Latino dysfunction. Basically, this narrative says Latinos have never done anything right. They're always the criminals, always the sickly, always the welfare dependency, always the gang bangers, et cetera, et cetera. They don't do anything good. That's a common narrative. So early in the pandemic, when we were reading some of the clinical studies from China and then Italy and Spain before it had hit here, researchers there, particularly where they had really heavy hospital loads, noticed that towards the end, patients that suffered either from obesity or diabetes tend to have higher mortality rates. Well, when people heard that here, said this suddenly fit their narrative. That is, Latinos can't do anything right. And so people said, well, Latinos are going to have a high rate because Latinos tend to suffer from obesity. They eat all those tortillas and chicharrones and everything else they shouldn't. They have diabetes. Plus, that Latino culture, they don't like to wear masks. They like to hug each other, shake hands. What do you know? And then, of course, immigrants. And immigrants are going to bring all this COVID over. They're infecting this country. They're part of that narrative about Latinos somehow are a threat to America. So the one narrative says, well, Latinos have higher COVID death rates because Latinos just don't function well. They don't do the right things. Well, I've been at this business for a long time. I look at the same data, but I see a different narrative. Remember, facts tell different stories, depend on who is picking them and placing them in a narrative line. So the narrative line that I have seen is that, in fact, Latinos have been functioning quite well. In fact, Latinos in this pandemic are actually the unimportant essential workers. That's what we forgot to recognize. I mean, early on, we made sure that physicians, nurses had their access to personal protective equipment, that they got training, they donned their equipment before they went in. We had negative pressure rooms, they doffed the equipment going out. We took a lot of care to make sure that they were covered so they could continue doing their job. We forgot that there were many other essential workers about whom we didn't think. We didn't provide them any personal protective equipment, particularly farm workers. Travel out in large buses, they work in huge cuadrillas, often shoulder to shoulder. They sleep in overcrowded houses. Thanks to them, we eat. In fact, if you remember the first 2 months of the lockdown when people were fighting in the grocery stores over paper towels and toilet paper, well, if it weren't for farm workers being exposed because you cannot do farm work in your house, in your living room, you actually have to go out. You can't bring your job in. Because they were being exposed to coronavirus, we were able to eat. And if it weren't for that effort, people would have been fighting for the last sack of tomatoes in the store. And that would have been some very serious fighting. So farm workers have been way overexposed, packing house workers as well. The meat packing plants in the Central Valley here in Los Angeles County, COVID has just ripped through because there, again, workers are closely packed together, working shoulder to shoulder. In the grocery stores, as you look at this checkout clerk, you imagine that between 200 to 300 people were passing within an arm length, and she wasn't provided any personal protective equipment. So she is being exposed 200 to 300 times. And this was going on across the country. The transportation drivers, metro drivers, bus drivers, the workers who cleaned the offices, the nursing home attendants, automobile mechanics, construction workers, gardeners, all these people were essential workers, but we didn't think of them the way we thought of the doctors and nurses, so we didn't provide them personal protective equipment. And of course, particularly in farm work, there are many areas where the indigenous communities are really suffering. So to begin with, we have essential workers, but they weren't considered important enough to be provided face masks. Then they're paid very little. From the story, even when Latinos work full time, sometimes they're still not making even minimum wage. They're still in poverty, but they're working. Housing costs in this state are sky high. And one of the ways that Latinos have dealt with that is we put more people in a household. We have more wage earners per household, more kids per household. And then of course we have the abuelos also living in the household. So we just simply have more people per household just to deal with the high cost of housing. And then the lack of insurance. Even after Obamacare, Latinos are twice as likely to be uninsured as non-Latinos. And of course, some occupations such as farm work are simply almost never offered insurance by their employer. So farm workers, very low pay, living in very crowded situations, very little insurance. And if, insurance is weird, what it covers, what it doesn't. If you have to pay for a test, and the test sites don't always say this is free or you got to pay. If you're paying out of pocket, that can be $100 a test, up to $2,000 for a test. And here's where the Latino physician shortage comes in. For the first 2 months, in order to get a test, you actually had to have a recommendation from your physician. I remember the California State Department of Public Health sent out this notice early, and it was in Spanish. If you've got the symptoms, you have a high fever, you got a raspy cough, hable con su médico pronto. But if you're a farm worker, what médico? I mean, you're living way out in rural areas. This is one of these things. Talk to your doctor. De inmediato. Well, we have this huge Latino physician shortage. It's big and it's growing worse. And it's even worse if you want to find a Spanish-speaking physician. And for those who say, well, they should be learning English, medical services have been provided in this state every day in Spanish for 251 years. So this is not a new thing. This is part of California history, providing services in Spanish. And then, of course, we have this administration's immigration policies. Besides blaming immigrants, saying that they're bringing the coronavirus in, when in fact coronavirus got exported from here to other parts. La Migra is continuing its redadas, particularly they put sanctuary cities right in their crosshairs. They're going to punish sanctuary cities. Here's a case in Colorado where a patient was admitted because he was coronavirus positive and he was actually had a full-blown infection. The agents from ICE went in, picked him up, took him out of the hospital to deport him. And then we deport a lot of coronavirus people have in the refugee camps along the border or in here, caught in the redadas, have picked up the virus here. Now they're being deported and sent to Guatemala, to El Salvador, to Mexico. Basically, we're exporting COVID to Mexico and Central America. Then, just in a very gratuitous slap at Latino families, that very first CARES package, remember, God, it seems so long ago, back in April, it provided extra money, extra unemployment, some help with rent. But if a household had one member that was not a citizen, now that doesn't mean undocumented, just not a citizen, a visa holder, whatever else, the entire household was excluded from receiving any aid from the CARES package. So as I look at this, I think, wait a minute, Latinos, we're doing our jobs, we're feeding everybody, we're doing all these essential work that makes this society function. It's the social systems that are dysfunctional. They don't reward that, they don't pay it, they don't protect it, they don't provide it access to care. And then, oh my God, why do Latinos have high COVID rates? It's not surprising. So remember, facts tell different stories, depending on who is picking them and placing them in a narrative line. We can either go the Latino dysfunctional, it's their fault because they're doing things wrong, or we can take the different line. Actually, they're doing the right things. They're making it possible for the rest of us to shelter at home. Maybe we should be providing them, at the very least, personal protective care. Maybe we should be providing them access to testing. How about access to medical care? Because after all, without them, we would not eat our 3 meals a day. Thank you very much. I'll turn my time back to you, Giselle.
Thank you so much for your presentation, Professor. You know, when we see these high rates of cases and deaths, it's so important to try to understand these patterns. So now we are going to have Dr. Laura Martinez. Dr. Laura Martinez was born in Compton and raised in Boyle Heights. She is trained as a biomedical scientist and received her PhD in the pathophysiology from the Department of Global Health and the School of Public Health at the University of Washington in Seattle. She is currently a postdoctoral fellow in the Department of Obstetrics and Gynecology, studying cancer immunology, and is a research associate at both CESLAC and the UCLA Latino Policy and Politics Initiative.
Good afternoon, everyone. We're just waiting for Abelardo to share our screen with our presentations. So it's a pleasure to be here with you today, and I'm very happy to share our work here with CESLAC and the Latino Policy and Politics Initiative. Thank you, Dr. Hayes-Bautista, for that incredibly comprehensive and synopsis and summary of how Latinos have been impacted during the COVID-19 pandemic. And so what I would like to take the opportunity is to discuss some of our research and how COVID-19 has impacted vulnerable communities, and specifically an examination by race and ethnicity in Los Angeles and New York City, being two very large metropolitan areas where we actually see increase of COVID-19 cases early on during the pandemic. And as we know, in Los Angeles, we have over a 48% Latino population. In New York City, it can range from 25 to 38%, depending on the New York City Bureau. Next slide, please. So what we started first is examining the data and looking over at how the confirmed cases look like for coronavirus early on, when we first started realizing that some of these cases were coming up in New York City, which we can see in the red bar graphs, in comparison to what we actually see the cases over time in Los Angeles County. So what we did is, for the data that I will be talking to you with you today, it will be presenting from the County of Los Angeles Department of Health, and also the New York City Department of Health and Mental Hygiene, which allows us to be able to look at the data over time, as well as the data for those that have been infected with COVID-19 and those that have died from COVID-19 by race and ethnicity, and also by other different group sectors. So one of the things and take-home messages here is that you can see that in New York City, we saw this really huge expansion of cases very early on when the pandemic first started there. Over time, we have seen that there has been flux. So there's several different peaks that have happened. So this data includes the most recent numbers. And in Los Angeles County in black, you can see that there have been several spikes up and down. And most recently, we see that we have been receiving increased number of cases. And in the last week, we have seen that there has been, in the last couple of weeks, we have seen that there has been a range of 5 to 15 COVID-19 deaths in Los Angeles County. Next slide, please. And so what we wanted to look at is how the Latinos and other ethnic minorities have been impacted. And what we found is that when we examined this data based off of all the age-adjusted cases per 100,000 population in Los Angeles and New York City, which I'll start with the data from Los Angeles, we find that Blacks and Latinos in Los Angeles are nearly 2 to 3 times as likely to die from COVID-19 than non-Hispanic whites. So here I'll just show you an example of what the data looked like when we were reporting this data and through the Latino Policy and Politics Initiative policy brief that we put out there at the end of July. And you can see that in Black, you can see there were 396 cases per 100,000 population for whites, and 23 deaths of 23 cases of death cases for those that were non-Hispanic whites. And if you compare and look at the Latino population and African-American population, you see that there's twice. But for Native Hawaiians or Pacific Islanders, which only comprise about 0.4% of the population in Los Angeles County, we see over 7 times the amount of deaths among this population. So it's a huge disparity. Next tab, please. And now that we actually examined the data most recently, not much has changed. So we have seen that there has been, as I mentioned, different waves and spikes of cases. But as you can see in this most recent data for LA County, now we're at over 2,300 cases per 100,000 population in Latinos, among Latinos, and about 100 deaths per 100,000 population. These numbers seem to be continuing to increase, and we still continue to see these disparities. Next slide, please. In New York City, the most recent data also has not changed over time, and we see that the most highly impacted has been the Latinos and Blacks, which are roughly twice as likely to die from COVID-19 compared to whites. Next slide, please. And so there are many factors that maybe actually contribute to why people might be impacted in certain levels to access to care. So one of the things that I wanted to talk to about is the social determinants of health, which are conditions and environment in which people are born, they live, learn, work, play, worship, or age that can affect the wide range of health and functioning quality of life outcomes and risk. And some of the examples here that I'm showing you are conditions that can be social, economic, and physical, and these areas and environments and settings. So what we wanted to do is look at different factors in the communities within Los Angeles County and New York City, and seeing what those different social determinants of health are actually impacting these communities at large. Next slide, please. So what we found is that people residing in extremely poor areas have the highest COVID-19 case and death rates in LA County. So as I mentioned, this is the data for the published also by the Los Angeles County Department of Public Health. And we see that you can see incrementally, you see that within the greater than 10% area of poverty, you see that there's about 1,700 cases per 100,000 population. And with that measure, the people living in poverty, that's about 10% of the population in that area, it's about 33. But as you can see that there's an increase in the number of cases if you get into areas where there's a higher level of poverty from 30 to 100%, and also in the number of deaths as well. I'm not going into the data for New York City here, but we also find the same parallels when we see that the people residing in these areas of extreme poverty also have the highest case and death rates. Next slide, please. And so what we wanted to look at is some of these determinant factors that may impact these people from obtaining the help that they need, and also the proper care. And so what we did is an evaluation of households within Los Angeles County and New York City. So we used the US Census Bureau data from the 2014-2018 American Community Survey. So these are 5-year housing estimates and public use microdata samples. So we can actually make a very direct comparison between these two very large metropolitan areas and look at the household level, the percentage of households that are living below poverty level. And you can see that in both major locations, there's about 15 and 18% of people who are living below the poverty level. There's 9% in Los Angeles County that are receiving food stamps and need help with food for their families. 20% in New York City. Those living with disability who may be impacted during this pandemic also by receiving the proper care that they need. And also people who are households with people that are living there 65 years and older or live alone, which will need somebody to help them along the process. And when we knew along the beginning of the pandemic that those older than 65 were highly impacted, and that's where we saw most of the death cases at that time. We also learned that there's multi-generational households where we have family members or extended family members living in a household. In Los Angeles County, there's 7%, and in New York City, there's 5%, which also impacts the level of people living together and possible overcrowded housing conditions, which would definitely impact the transmission of the coronavirus because it's highly transmissible. Next slide, please. And so we also look, the previous one, please. Yeah, so we also looked at households who are struggling and without access to technology in both locations. And yes, you can see, here you see the direct comparisons where there's still a proportion of the population that do not have access to internet in their home, who also don't have access to broadband or internet technology or laptop or desktop. So within New York City, we have 20 to 24%. There's still population people who don't even have access to telephone service. And most impactedly, smartphones or portable wireless computers, which actually are very important when we are, with Dr. Hayes-Bautista mentioned, and them not being able to see a physician in person, but they need to have access to this technology so they can conduct their medical visits online through telehealth services. And Dr. Anaya will talk a little bit more about this. So these are different things that definitely impacts their ability to be able to get the care that they need. And they will continue to struggle with over time if these needs are not met. Next slide, please. And so one of the things that we also looked at is obviously the population of people without health insurance. So we're finding that in Los Angeles County, there's 11% population that does not have access to health insurance. In New York City, there's 8%. Next slide, please. Next tab. So one of the things that we can also look at is the breakdown of what this looks like overall for even by age group. And as you can see in these two different diagrams here, you can see in Los Angeles County and New York City, there is relatively a very young demographic population demographic of people who don't have access to health insurance. Even between the ages of 19 and 34, there's about 49% of the population that doesn't even have access to that and to be able to get the help that they need when they need to be met. And we see the same thing with the population of individuals that are even under the age of 18. So that is a major concern for us in thinking about people who can actually be able to get access to health or even conduct the telehealth visits that they need, and especially as we see a higher rise of COVID-19 cases among the younger population demographic. Next slide, please. And so one of the other factors that may influence is the language capability of the individuals to be able to access what they may need and also be able to conduct these telehealth visits with physicians that may be able to meet their language and capability and communication, which is very important for them to obtain the information that they need and preventative care that they need at this time and beyond the pandemic. And so here's just a breakdown of the population of, we see that in Los Angeles County, New York City, there's about 44 and 50% that only speak English, but we also see a very large percentage of them that speak Spanish only in their household. So these are 35% in Los Angeles County and 24% in New York City. And we also have to acknowledge that there's many other languages that other people speak in their households, so they might have a limited English proficiency. Next slide, please. And lastly, the piece of data that I'd like to just show you is also what's very important and something that Dr. Hayes-Bautista touched upon. So we have a very large immigrant population in these very large metropolitan areas. And so we wanted to examine the foreign-born population in both locations. And as you can see, that it's very comparable where we see about 34% in Los Angeles County and 37% that are foreign-born. And if we look at these specific subsets, we see that in Los Angeles County, we have about 60% of those that are foreign-born that are living with two parents that may be foreign-born, and 59% for New York City. And 49% of those are not US citizen in Los Angeles County. And in both locations, their ability to speak English, that's also a determining factor in them to be able to take the care that they need, as I mentioned earlier, or they may speak a language other than English at home, as we just talked about. And lastly, they're still dealing with not having access to health insurance when we have a 19% population in Los Angeles that are not going to be able to have it during this time or even after the pandemic. Next slide, please. When we break down what this foreign-born population looks by race and ethnicity, you can see that a large percentage, 55%, more than half, are Latino or Hispanic, and about 2% of the total of the population in Los Angeles, it's 9% in Los Angeles County is Black, but you can see that 2% of those are foreign-born. And among that as well, we also see that there's over about 28% in Los Angeles County and 27% in New York City that are Asian and foreign-born. So next slide. So we wanted to be able to discuss this data with you. We don't have an opportunity to go all over it, but we invite you to actually review our research and policy brief that we published through the Center for the Study of Latino Health and Culture and the Latino Policy and Politics Initiative, which you can find at latino.ucla.edu. So this is in collaboration with Dr. Bustamante, Dr. Anaya, Sonia Diaz, and Dr. Hayes-Bautista, which is here with us today. And one of the things that we actually offered here in our next slide are policy solutions and being able to meet the needs of these vulnerable communities in Los Angeles and in New York City and in California. So I'm going to go over a couple of these different things that we actually propose as potential recommendations that we can work at the policy level and also community level. Next slide, please. So in recommending to improve outcomes for access to care and testing, we need to continue to ensure that there's access to testing from low-income communities of color, and that this continues to increase this access to be readily available upon testing with rapid turnaround time, as well as to continue to establish testing sites in residential areas with high concentrations of overcrowded housing. Next slide. Some of the important key elements that we also discussed is like people who don't have access to certain resources that are key for them to be, for the survivability and for them to be able to overcome all these stringent conditions during the pandemic. And that includes the important relevance of being able to provide and give access to resources and safety precautions that are necessary, such as health and nutritional resources that needs to be available for families that reside in high poverty areas, and also to provide state and city supportive programs for the undocumented who are ineligible for federal assistance programs. So some of the things that we propose here is to be able to expand food assistance programs and meals that can be provided at schools for children and adults and seniors, invest in emergency meal delivery services for those who do not have access to food and they cannot commute to these service locations, and ensure that food security and healthcare access for essential workers and for those who are recently unemployed and who have lost their employer-based healthcare, we are able to continue to have healthcare access. Next slide. I didn't have so much time to go into data, but there's still a population of individuals that must rely on public transit and who live in at-risk neighborhoods. So it's still important for us to continue this, wearing our masks, make sure that those are available at bus stops and parks and recreation areas where more people are actually going out to now, and can continue to require them to wear those masks on board. And if they don't have access to them, make sure that they are provided at no cost. Next slide, please. We want to be able to make sure that we can expand and enforce workplace health and safety regulations to protect workers long-term, especially not essential workers, as Dr. Hayes-Bautista touched upon. So in order to be able to do this, we have to ensure that there's adequate access to Medicaid coverage, support policy efforts to provide paid sick leave for all workers, and also provide employee protections for undocumented communities and those employed under work authorization agreements, so we can make sure that these essential workers have access to the proper protective equipment that they need at the workplace. Next slide, please. And lastly, we want to be able to supply members of low-income areas with technology necessary to access to health. I'll just briefly say here that we need to be able to reduce the cost of broadband internet services and be able to subsidize these costs for people who are living in medically and linguistically underserved communities, because we need to be able to encourage them to be able to have the telehealth visits so they can continue their care, especially among those that are living with comorbidities or dealing with chronic care management. And in the last slide, I would just touch upon how we need to, next slide, please. We need to remember that in order for us to be able to support local and national policies, we need to be able to invest in research programs that can alleviate the burden of COVID-19 on vulnerable populations. And this means investing in services for underserved communities to address the structural issues highlighted in the things that we've discussed today, and as well as work with having community leaders and public health officials and professionals in the health and scientific disciplines in order for them to develop long-range recovery plans while we're including health and equity advisory committees. And we need to invest in funding for research studying COVID-19 related racial and ethnic health disparities. And in the last slide, I just want to acknowledge, thank you for being here today. I want to acknowledge the CESLAC team, the team Dr. Hayes-Bautista, Zeta Santizo Greenwood, the Chief of Staff, Adriana Garzon Valdez, and our research assistants at CESLAC, Giselle and Stephanie Hernandez. And we wanted to also acknowledge Sonia Diaz, who is the founding executive director of the Latino Policy and Politics Initiative and her research team there, and Dr. Vargas Bustamante, who is faculty director of research and also contributed to the work that I presented today. Thank you.
Thank you so much, Dr. Martinez. Thank you for sharing your research with us. And you see how disconcerting it is to see these trends and disparities across these two big US cities. But yes, and to the participants, if you have any questions about her presentation or Dr. Hayes-Bautista's presentation, please enter that information in the chat or the Q&A, and we'll get to it all at the end. So now we are going to have Dr. Yohualli Anaya. Dr. Yohualli Anaya is an assistant clinical professor of family medicine at the David Geffen School of Medicine at UCLA. She teaches residents and medical students at both the Mid-Valley Comprehensive Medical Center and the UCLA Family Health Center as well. She also has a continuity practice at each, And Dr. Anaya is a faculty expert for the Latino Policy and Politics Initiative and collaborates on research here with us at TESLAC.
Thank you, Giselle. Thank you for having me. And I hope to bring you the perspective from the front lines of caring for underserved and vulnerable populations. We can go ahead and load the PowerPoint now. So the COVID-19 pandemic has brought to light the inadequacy of our existing health infrastructure. While necessary, yeah, that's perfect. While necessary, our efforts to prevent patient exposure to the virus led to disruptions in patient access to care. While healthcare systems were forced to quickly try to figure out how to provide patient care at a distance. And basically overnight, we switched to largely only being able to care for patients via telehealth for months. And because of the lacking system level infrastructure for this, patients across the board experienced disruptions in access, but this was particularly magnified in Latino and other vulnerable populations. In addition, there's been a prioritization and a triaging of care needs that physicians have had to do, especially pronounced in the first months of the pandemic, and particularly affecting services that are considered routine and therefore non-urgent. To give you an example, exams such as cancer screenings were postponed in hopes of minimizing potential exposure to COVID-19, but in the safety net, these delays have created a massive backlog of these diagnostics like colonoscopies and mammograms, for example. But what we call routine care is vital to keeping our most vulnerable patients healthy, not only amid a pandemic, but particularly in the long run, because poorly controlled chronic diseases and delayed cancer diagnosis will further exacerbate healthcare disparities and result in people living shorter lives. Next slide. As Doctora, oh, one slide back. There we go. As Dr. Martinez highlighted, Latinos and other minorities are at increased risk of getting sick and dying from COVID-19. And this is because of long-standing health and social inequities, which have put us at high risk. These inequities are often referred to as the structural determinants of health because they are structural issues of the society that we live in that determine and sometimes prevent our communities from having fair opportunities for economic, physical, and emotional health. So I want to share with you one of my patient stories to help you understand the implications of these inequities. So we're going to call him Mr. F. He's a working age Latino. And I'll say this is a real patient story. So he lost his main job as a busboy in a local restaurant as a result of the pandemic. Because of this, he's been collecting and crushing cans with his right foot to supplement his limited income. He's been very, very stressed by his finances. He has diabetes and high blood pressure, and because of the combination of these and the years of poor control of these conditions, his blood vessels that keep his body parts healthy, like his limbs, have become narrowed and clogged. This is called peripheral vascular disease, and essentially it becomes poor circulation is what happens. He tries his best to eat right, but controlling his diabetes has been very hard. And today, the measure of his diabetes control, a blood test that we call an A1C, shows us that his blood sugar levels have been very, very, very high. He states that his clinic has not been seeing patients in person since the pandemic. And so he's only had phone call appointments to refill his medications. No doctor has seen or examined him in many months. And he has not had an A1C in many months either. He's here in the emergency room. He's about to be admitted by my team for evaluation of swelling and discoloration of a toe on that right foot, the foot he uses to crush cans. He doesn't have pain, he feels well, but because it hasn't been getting better, he decided to come in and be seen. He's also had an ulcer at the bottom of this same foot since May, but he was too scared to come in to seek care for it because of the coronavirus. On our exam, his foot is severely infected. He has multiple ulcers, and his x-ray shows that the infection may have traveled through the ulcer all the way to the bone. Mr. F has already had an amputation of half of the toes and foot of the left foot. And as I mentioned, his livelihood depends on his physical ability to walk and bus tables. Mr. F was found to indeed have a bone infection of that right foot and required amputation of half of the right foot and toes on that side. He has restricted Medi-Cal, so he won't be able to continue to receive care in the UCLA podiatrist's office after his follow-up for the surgery. What will Mr. F's primary care follow-up be like? Will he be able to walk without disability? Will he be able to continue to make a living for his family? Will his foot and surgery be able to heal without having good circulation? Will he have appropriate evaluation of that foot and the other foot over the coming months and years to prevent this from happening again? Could he have had better options for interventions of his foot if he wasn't underinsured? Hard questions to grapple with. And this man's outcome in future will forever be marred by not just the impact of COVID-19, but of how COVID-19 magnified the inequities that he was already facing. Next slide, please. The social and structural determinants of health similarly contribute to the risk that our communities face from COVID. These include discrimination. Just the last time that I was in the hospital taking care of patients, I took care of a gentleman who told me about how he was mistreated by healthcare workers at the hospital he was transferred from. This racism and discrimination makes our communities not trust the healthcare system and potentially hesitate to seek care because they distrust the system. Access and utilization. The issues here not only reduce healthcare access in the ways we traditionally think about, as Dr. Hayes-Bautista was also describing, but healthcare access can also be limited by many other factors, such as lack of transportation or lack of the ability to take time off work, communication, language barriers, cultural differences between patients and providers. And in addition, sometimes patients may delay getting care out of fear or sometimes a preference to rely on remedios at home first, even when they have access to care otherwise. But these delays can quickly translate into greater risks for our communities. Occupation, Latinos and other minorities are bearing the brunt of COVID, as you have heard. And working in these settings, these essential work settings, can lead to more chances of being exposed to the virus due to having close contact with customers or other workers, not being able to work from home, or not having paid sick days. In terms of housing, Latinos may be living in multi-generational housing where maybe young members of the family go out to work or even for pleasure and bring home their own exposures to more vulnerable members of the household who may otherwise not be going out. Many abuelas also help their children with caregiving amongst Latinos, and this is another potential source of exposure. This happened to one of my patients, actually, who takes care of multiple grandkids. Both she and her disabled son got the infection from the granddaughter who my patient babysits. She is still in the hospital requiring high levels of oxygen support to breathe. And then finally, inequities to access to high quality education may limit job options and lead to lower paying or less stable jobs, like in Mr. F's case, for example. They may have less flexibility to leave jobs that put them at higher risk. And also folks in these situations often can't afford to miss work, even if they are sick, because they need that money. Next slide. So the barriers to adequate care for our community during the pandemic have been occurring on both the patient and provider sides, but these ultimately affect patients and Latino patients and other vulnerable patients disproportionately. And unfortunately, we're already seeing how many Latinos are being left behind by our sudden transition to telehealth with the onset of the pandemic. And that was one of the topics of research that our group focused on during the pandemic. For example, where we could really be providing at least some care at a distance and a better system, there are patients who are stuck between taking a bus to come into clinic so we can evaluate something, or only having phone visits, like our patient, Mr. F, without the ability to have any visual exam because their health center doesn't have the ability to offer video visits, or because they don't have the tech experience that is needed to launch a video visit with their doctor. However, telephone visits aren't always enough, and these limitations have highlighted the importance of and need to address equitable access to broadband and video-capable devices for underserved communities in the long term, and the need to support clinics building up their capacity to serve vulnerable patients through telehealth in the short term. Next slide, please. We're worsening existing healthcare and access disparities if we set up our telehealth systems such that only advantaged populations can use them. Not only have patients been affected by their lack of devices or broadband to support video visits, but also by their providers' lack of equipment or EMR system capacity limitations for providing these visits. Black and Latino adults are significantly less likely than whites to own a computer or have high-speed internet at home. And if the telehealth systems that we employ require video visits or portal access to occur via a computer instead of smartphones, for example, you're physically excluding about half of the Latino population from access. So providers and healthcare systems will need to be supported in order to incorporate things that include Latinos, that consider Latinos, and how the system is refined and reimagined. Next slide. So offering some recommendations. Next slide, please. How do we start improving access to care for Latinos? First, we need to identify and meet the needs of both our patients and our providers. We recommend that our healthcare system's vision really be to meet consumers where they're at. And this means taking into account both our patient consumer base, of which specifically in California, Latinos make up almost half of that market share. As an example, with our new era of healthcare delivery incorporating telehealth for the long run, we need to think about what that means for the technology we're employing and the languages that that technology is produced in. We also have to take into account our provider consumer base. What is it that they need to improve access for their patients? Next slide. With regard to some of those specific structural barriers we mentioned earlier for telehealth access for our patients, to ensure access for our community, we need to help patients get to their virtual visits. In the same way that we would provide transport for low-income patients to physically get to their appointments, we've got to ensure patients can virtually get to their video appointments by making sure that they have the needed devices and broadband access, and by providing tech support for patients as they learn to use telehealth technologies. For our limited English proficiency Latinos, we need to ensure language assistance at all points of contact, including in the technology and tech support aspect. Next slide, please. On the provider side, it's important that we fund access to technology and equipment for primary care providers and provide funding for clinics to provide that technical support for patients that we talked about. Next slide. When we as physicians see patients, we're wearing masks, I'm wearing a mask. And in most situations, we're also wearing eye protection. I'm often wearing a shield to ensure that we're appropriately protected because of the way that spread and infections occur. So as a corollary, to improve outcomes for Latinos amid the pandemic, it should make sense that we need to ensure that the rest of our essential workforce is also protected from exposure the way that I am protected when I'm taking care of patients. As we've seen, Latinos as a community are not the ones who get to work from home. They need to have appropriate PPE, and the people that they interact with, in other words, often the customers, need to be wearing masks. Work settings need to be also providing appropriate social distancing. And in settings where, for whatever reason, that's not possible, as Dr. Hayes described, we need to think beyond a mask and consider the addition of shields or other appropriate eye protection in addition to the masks as worker protection, similar just to how I wear it when I am close with patients. Next slide. The way forward also involves expanding the supply of Latino and language capable physicians to care for our community. We need to support Latino students so that they can make it and incentivize schools to prioritize their recruitment and matriculation. Next slide, please. And to finish with some recommendations for patients and families. No matter what certain people might say, I can guarantee you that wearing a mask works. What's most effective is for you and those that you're interacting with to be wearing a mask. This cuts the possibility of transmission down by a lot, as you can see in this diagram. Know that it's estimated that almost half of transmissions occur before symptoms arise. So we really do have to minimize our interactions with people, and especially those where there are folks that are not wearing a mask. The other thing I'll say, be wary of misinformation. Latinos are particularly vulnerable to misinformation because of engagement with social media, the way we use channels like WhatsApp to information share, but Latinos are actually being targeted right now with misinformation. For families in which someone becomes infected, sometimes you don't have the option to use a different bathroom. There is only one bathroom in a household. So in those cases, everyone in the home should be wearing a mask to minimize the risk. If that's what we can do, everybody can wear the mask in the home. And if you or your loved one becomes infected, the biggest advice that I can give you is to seek care immediately and not delay care if you're feeling short of breath. Once patients feel short of breath with minimal activity like talking, they can deteriorate pretty quickly. And so getting to an emergency room in those cases as soon as possible is key. And generally, I'll just add that, as highlighted by the story of my patient that I shared with you today, and this is not a solitary story. These are stories that I see all the time. I know that there are many reasons that we delay care, but I plead with you to give us the best chance to make sure that you and your loved ones have a chance, and don't delay care. Next slide. And with that, just a big thanks to CESLAC, also LPPI, all the folks at both locations, and I'll turn it back over to you, Giselle.
Thank you so much for your presentation. So now we are going to take questions from participants. So one of the first questions is that I have is that, so when we see these social systems failing communities, what can be done, and what can be done especially like on an individual level for people to change something like that? So I will leave that for anyone to take.
Well, I'd like to take a crack at that. There are a lot of things that we have to deal with today. For example, student loans. When I went to the University of California 65 years or 55 years ago, I went practically for free. Now, I was the only Latino at UC Davis. Then I transferred to Berkeley, where there were 25 Latinos. But I paid $108 a year. My children graduated from the UC system paying tens of thousands. In fact, I think my son is close to about $100,000 of student debt. What made the difference? Registering and voting. That people voted in 1978 to basically cut funds off to the university, to public schools, because they didn't like paying for children being educated. So if we want to change that, we need to register and vote. That'll change the technological infrastructure, access to care, all these sorts of things through registering and voting. We have the problems because we have not had our electoral voice heard. Now that Latinos are a large part of the electorate, we need to make sure that we then raise our voice and vote. And we have an election coming up very quickly, and vote consistently, vote every time there's an election. That's probably the most important thing we can do to change these large things around us, so that we individually can then create the type of lives that we want.
Thank you for that.
I completely agree with Dr. Hayes-Bautista. We're a little over a week away from elections, so make sure that we can do this and vote early. This is a very important election for us as well. And as you're aware, there's also been, this is the year where we have the 2020 census. So as a community, we should be invested in being able to complete these surveys, so we have a good idea and measure of different population groups, people, their households, where they're living. And I just recently received a survey about how the COVID-19 has impacted my household, and also ability to work or ability to access care. So just make sure that you help your family members and contribute that way, and being able to participate in these very important civic and engagement opportunities to be able to contribute to society in general. So I think that's really important, if you can take that responsibility onto yourself to be able to help your friends and family members, remind them, and then also help them fill out those ballots, which it's a really important process. And we're, like I said, we're so close to the election time.
And vote for those who cannot vote.
Thank you so much. Dr. Anaya, I think this question is going to be for you, since it's about telehealth. What can be done to address these issues if low-income families do not have access to a computer or technology to access telehealth? And what about those individuals that do not know how to use or navigate the platforms used for telehealth? How can they, personally be assisted?
Yeah, so this is something that is going to have to be addressed, honestly, the first part of the question at the policy level. So making partnerships with the organization, the providers of smart devices, of broadband, so that we can provide access to our most underserved patients and who really are the most vulnerable, as we discussed. In terms of making the technology something that we can use. So, initially it's going to have to be a lot of technological support. So ensuring that primary care offices have somebody that is dedicated to helping your patient download whatever app needs to be downloaded, literally walking through the process of push this button, now push that button, now add this, now add that. And in the long term and kind of at a more systems level, we need to start to think about, again, thinking about our consumer base, right? So we need to design technology and not accept anything else that actually meets the needs of our patients, so that it should be straightforward, that it's not complex, that it doesn't require an email, because of a lot of our elderly adults don't use email, don't have an email address, they can't keep track of the password, that we use things that are the channels that Latinos are already using, and then we can provide education for our patients. Latinos use YouTube a lot, use Facebook a lot. We can live stream, just like we're live streaming this event. We can live stream education for our patients on how to use our platforms, on how to generally use the internet, and can you imagine how effective we can be by empowering our patients with the skills, the capacity to be able to do this, not just for downloading this particular app, but so that I can become effective with technology in the long term for anything that I need it for.
Thank you so much. And I have more questions coming in, but I think we'll only have enough time for about one more. So let's see. LA County's Public Health Department reported narrowing the disparity gap in testing. Did you track any improvement in access to testing and its correlation to infection and death rates? And then also in terms of the language barrier, can you elaborate on how significantly that has impacted only Spanish speakers when it comes to testing and care in relation to COVID-19 in LA County?
Can I take a crack at that last one? What we have, interestingly, is a high collinearity between language, that is Spanish versus bilingual versus English dominant, and immigration status, and they're very much collinear with occupation, that is farm workers, or about 100% Latinos, about 100% immigrant, and probably about 50, 60, 70% undocumented, depending on the crop and the time of year, et cetera. You rarely find a US-born English dominant person working in farm work. So farm workers are very poor, not because they're immigrant, but because that's the occupation that they're in as part of our racial structuring of society. So we need to understand that because certain occupations are occupied by immigrants and they tend to speak Spanish, and they will have high COVID rates, it doesn't mean that the Spanish is causing that. It's because of the structure of the situation of occupation and industry that they're working in. So we need to be careful. Let's not blame the victim here, that somehow if they only just learn English, they wouldn't have been exposed to coronavirus. They get exposed because of the nature of the jobs that they do, and immigrants are channeled into certain jobs. Bilingual have access to different types of jobs that allow them to actually stay at home and do the job from home. So let's look at the structuring of the occupations here in California.
Okay.
Dr. Hayes-Bautista, I just wanted to briefly just answer that in terms of the data that I presented. I think this is a really important question, and that's something that we did discuss in being able to look at access to the data of testing that is being provided in Los Angeles County. But when we started looking at very early on, that information was barely becoming available. When I was tracking this in June and July, over time, it has become more available. So it's something that it was really important to be looked at. But also there's still a portion of it that they may not have complete sets data information for where testing is happening. So, but there's more efforts now with the Department of Public Health to do the contact tracing. So I think that that will provide us the opportunity, as well as understanding more, because that testing data does not specify whether those people are Spanish speakers only or with the limited English proficiency. So that's something that I think is really important to address. And I also see a last question there about housing cost, which is impacting living conditions in Los Angeles because it's so expensive. And I think that's incredibly important to also address. And there's very many different policy measures and things that we need to be able to look at in order to be able to improve the access to affordable housing in California overall, and then in Los Angeles as well.
Thank you so much. Okay.
There was a question in the chat requesting the link for Dr. Martinez's paper, and so I just placed it there as well so that folks can access it. And this is, that you can use this also to access any of LPPI and CESLAC's joint work as well.
So any last words from the panelists?
You want to do something? Register, vote. And if for some reason you're not able to register and vote, then find someone who is and encourage them to register and vote. We must make our voice heard.
Thank you.
Thank you so much, Giselle, for moderating. You did a great job. Of course, Dr. David Hayes-Bautista, Dr. Yohualli B. Anaya, and Dr. Laura Martinez from UCLA. Fantastic. We got some nice responses on our Facebook page, at least people tuning in. We have Viviana Andrade, powerful presentation of such important data. Thanks for all your analysis, folks. We have an incredible challenge facing our community. We have Sara O'Connor Rodman Alvarez was viewing from South Pasadena, Glenn Rader from Sacramento, Linda Collins, redefine essential with appreciation and care, health, financially, and in our communities. Without them, there's no us. Heartfelt thanks. She's coming in from Elk Grove, California. Those of you who tuned in a little bit late, we will be posting this entire presentation on our YouTube page at La Plaza LA and on our Facebook page at La Plaza LA, and then also on our website, lapca.org. You can find all of our presentations of En Casa con La Plaza on those platforms. Also, our upcoming sessions, you can find them at lapca.org and on our Facebook page. And speaking of the election, this Wednesday on En Casa con La Plaza, we have Decisión 2020 election roundtable moderated by Mirtela Salinas from Estrella TV with Luis Alvarado, Hernan Molina, Hector Sanchez Barba from Mi Familia Vota. And then on Friday, we have Dan Guerrero, a good friend of ours who comes to us every 2 weeks. She'll be with an advocate, an icon, the one and only Dolores Huerta, who will, of course, be encouraging us to vote as well. So with that, thank you to our panelists, our sponsors, SoCal Gas and California Humanities, and all of you who viewed in today. Join us again on En Casa con La Plaza. In fact, this afternoon, we have another one. We have our regular Monday series, En Casa con La Plaza Cocina, in which our good friend Maite Gomez Rejon will be demonstrating how to make enmoladas in honor of Dia de los Muertos. So thank you to all. Have a great afternoon. Adios a todos. Nos vemos pronto.
Thank you.
Adios.
Thank you for having us.
Bye-bye.